Well, hello everyone. Welcome back to the Caring Neurologist with Dr. Sandeep Thakkar. I know I've learned a lot on the first episode. I'm pretty sure you did as well. And today we're going to do sort of a 101 Parkinson's for those who do not understand anything. Let's go to the roots of it all. I know it is a scary subject. It is not easy to talk about because diseases, and please correct me, doctor, if I'm wrong, but diagnoses of diseases such as Parkinson's um, scare people, and
Definitely.
y- you
Yeah,
immediately think that's it.
exactly. The first thing is these misconceptions, right? It's fatal and there's nothing you can do about it. And it's really tough for patients, tough for family members. Hearing those words can be, like you said, devastating.
So let's try to go deep into this and try to understand Parkinson's because in life, I've learned that the best way to cope with something is to understand it. And the more you understand it, the more you can control it. So this is Understanding Parkinson's and Movement Disorders 101. I am going to begin by, of course, thanking Dr. Takar for all the information he shares with us. And let's go to this idea we just talked about. When people hear Parkinson's disease, or movement disorders, they might think they know what it means. They picture Michael J. Fox, or they picture Muhammad Ali.
Hmm.
But reality, these conditions are far more complex than that. So let's go to the basics. How would you define Parkinson's disease in a way that anyone listening can understand?
Yeah, I don't know if we can do that in just one episode, even, right? Because there's so much that encapsulates Parkinson's. And, with the term Parkinson's, there's a lot of neurological disease states, as we'll talk today about, that are mimickers. But at the core, again, it's a neurodegenerative disease. So there is degeneration of pathways of the brain that then sends signals to the rest of the motor control centers, to areas for focus and attention. So it is a degenerative disease state predominantly of a neurotransmitter in the brain called dopamine. And if it was just simple as it's just dopamine, then, refilling the system with dopamine would fix everything. But that's not the way it works. There's pathways of degeneration that send signals to acetylcholine, norepinephrine. So there are a complex network of degeneration, but you can still, again, function as best as one can. But it is a motor control disorder where in the beginning you may see certain symptoms of tremors, you may see certain symptoms of muscle rigidity, coordination, maybe even balance issues as the disease is progressing. But it's a slow progressive disease. And that's another very important thing, is that this is what I tell patients is it's a disease of decades. As you pointed out, Michael J. Fox, Muhammad Ali, um, 30 years each with Parkinson's and Parkinsonian symptoms. So it is what you may see of diagnosis, thinking of it just being for the elderly, and that's not the case, right? We're going to talk about young onset patients as well, but it is meant to be a slow progressive disease. I think one thing, Ursula, is when we get diagnosed late, it's even scarier because symptoms have progressed and we hadn't been have the ability to do much for the disease state. There's a lot that can be done, and as I commented, it affects motor symptoms. It may affect sleep patterns. It may affect so many different aspects of non-motor as well. The key thing with the 101 is getting to the diagnosis correctly, getting into a neurologist, maybe even someone like myself, a movement disorder specialist, and getting the proper diagnosis, and then understanding that is not something that has to be fatal, right? Like, this is not what people die from is Parkinson's. It's the heart attacks, it's the strokes, it's the infections. These are the things that we have difficulty managing. With Parkinson's, again, it is a manageable disorder when we are on the right and appropriate types of dopamine therapy.
Dr. Takar, can anyone get Parkinson, or are some people more prone?
Unfortunately, we're all human, so we are going to experience anything that everyone else can get to, right? Like, unfortunately, I think you live long enough, there's a chance of us getting cancer. The way I look at Parkinson's is kind of very similar to the diabetes world, right? There's a genetic factor that we can get Parkinson's, and then there's the environmental factors of getting Parkinson's. And what we do know is there's maybe less than 10% of our patients that come in are actually getting Parkinson's from a genetic aspect where it's running in families. Now, we're going to learn more and more that there are more genetic causes, and there's a lot of research about the genetics of Parkinson's, but it doesn't mean it typically has to run in family members. Now, the environmental factors is what makes the risk factors that anyone can get Parkinson's. So I was fortunate enough in my training to work with veterans and through the VA affairs here in the US. And, you know, there are those that were exposed to Agent Orange and other chemicals when they were in the military, and there's a higher predisposition potentially for developing Parkinson's in such groups. We see gardeners, exposure to pesticides, farmers, that industry have higher rates of developing Parkinson's, and in areas even around and surrounding those farmlands. So we're seeing in California that there are areas of high intensity, high heat maps, so to speak, of developing Parkinson's. So I think that unfortunately, in the environmental factors, we believe 90% of those diagnosed with Parkinson's because of environmental toxins. Again, even in my clinic, we see dentists. I mean, they were in their training, right? And they're in one's training when they were younger, we're going back 30 plus years, they were using mercury even in their lab kits and tools. So there's a lot of exposures that can have happened in the past. And what we're also seeing now, and I work with ex-NFL, ex-professional athletes who've had head trauma, and that puts us also at a high risk. And we're seeing that CTE is not just a mood issue, but it affects certain pathways again of the brain. Some of the deeper structures, we call it the basal ganglia, where the dopamine receptors are, and that's where they're produced. And we're seeing trauma to the brain can also increase the likelihood of developing types of Parkinson's.
Doctor, one thing that I've noticed in conversations is that many people do not realize um, Parkinson's is a part of a bigger group of conditions that is called movement disorders.
Mhm.
Could you please elaborate?
Yeah, so we think of a disease state is just, okay, this is Parkinson's, but Parkinson's is one of numerous movement problems that patients see or people get. Okay, so number one is I did a fellowship, fortunately, a subspecialty fellowship in movement disorders, and that encompasses Parkinson's. Probably 80% of my patients are dealing with Parkinson's, but there are those that suffer from essential tremor, that can mimic Parkinson's. There's disorders called cervical dystonia, where there's involuntary movements of the neck, and it can make the neck pull forward, or even tremor in the head. We see different types of limb dystonias or generalized dystonias, where again the entire body could be rigid, progressive, where they're walking very cramped forward. We see other movement disorders of the eyes and facial muscles. There's movement disorders from drug-induced circumstances where patients are on drugs for mood or for sleep, for psychosis, and they develop something called tardive dyskinesia, where there's an involuntary movements of the face and body. There's again, we see that even these drug-induced situations can mimic Parkinson's, so we call them drug-induced movement disorders. And then even more within the world of Parkinson's, we call them atypicals, where they're more fast, progressive type of Parkinson's disease states. Fortunately, we are uh, in the forefront of a lot of understanding of movement disorders, and so we can um, do the appropriate brain scans and make sure that we're dealing with one disorder versus another. One of the biggest mimickers, actually, Ursula, that I see is something called normal pressure hydrocephalus. And that's pressure within the brain, the ventricular system, the water system in the brain, because everything needs to be taken in and flushed out. And when that ventricular system, the fluid in the brain, so to speak, is enlarged, it puts pressure on these deep structures of the brain that then can mimic Parkinson's. So there's a lot of disorders that we see in the clinic not just Parkinson's, but that does take up the majority of my clientele.
Doctor, and this is me being 100% hypochondriac. How do we tell apart regular, normal movement disorders that mean nothing, like you were sleeping and you just, I don't know, moved your hand,
Yeah.
from, hey, dude, I have got to go to the doctor. This might be serious.
Yeah, well, number one, we're all in some form hypochondriacs. If we don't think about it, sometimes we neglect what's going on with our bodies. So I think number one, it's probably better to be a hypochondriac than not, because that means you're getting in to see someone. And I'll
My
tell
mom
you,
would love what you just said.
well, it's important because there's those that forget or don't want to hear what's going on. They're scared of what it could be. Um, and I think education is a big part of it. So education, wanting to know, being mindful, because again, in movement disorders, there are a lot of things we can do to manage and treat each of our conditions. But you brought up a very important thing. We all kind of go through this jerk, like when we're asleep or about to fall asleep. We call it myoclonus. Again, another movement disorder that we see. We see sleep disorders that have a lot of movement issues. We have daytime movements and jerks and spasms of the body. But that myoclonic jerks, you can see when you've been really pushed to the edge. You know what I mean? You're really tired, really fatigued. Some people, again, like you and I, we got our witch's brew of coffee, right? Like we can be tremulous, right? We can be tremulous. Um, there's a lot of pressure on people nowadays that they have to perform, and even kids, they're on Adderall and certain types of stimulants to focus. So we see that a lot of us do suffer different movement issues, and the body can feel even anxious, and internally people have what's called internal tremors. So there's enhanced physiological tremors that we get from, again, our coffee, and maybe even lack of our nutrients, right? We see a lot of deficiencies in our system with like vitamin B12 or vitamin D, and they could also mimic movement disorders and muscle spasms.
um, I do think this kind of changed with Michael J. Fox, but still, a lot of people assume that Parkinson's is just a disease of old age. It's like you're getting old and you get Alzheimer's or Parkinson's, and that's about it. Um, I don't think that's true. And I probably because I'm part of the generation that saw when Michael J. Fox was being diagnosed. So what do we know about early onset Parkinson's?
Yeah, number one, I want to make sure I don't forget this, because I like have such admiration for him. He is an amazing soul. I don't even know him personally, but you feel him. Watching still and a lot of his interviews. One day I want to be able to meet him and just give him a hug and just say thank you, because he's provided so much from his foundation for research, and the goal of bringing in funding and making sure that the research is funneled in properly, and dedicated to Parkinson's. Like, a lot of things that we do through the NIH, there's some delays that go through it, and I think his foundation has done an amazing job of awareness and um, pushing the envelope of where research should be. So it's amazing, and for him to be such an advocate, um, you know, we're all private, right? It's hard for us to talk about our issues. Um, from what I've seen of his wife being so supportive as well, you know, this is a disease that does affect young people as well. I mean, I've had patients in their 20s with diagnosis of Parkinson's, and it's hard to see 20-year-olds, 30-year-olds, 40-year-olds who are in their prime of their life, physically great and doing well, but they're like, I can't coordinate my hand well, or my foot's not coordinating well, and something's wrong, and they know something's physically wrong. So you're right, it is not a disease of old age, and you know, we all age differently, but when we're not able to coordinate our body, when we're having issues, it is important to get into a doctor, because there's something could be, again, mimicking those situations from a health standpoint. But we are seeing that again, there could be genetic factors that make someone get get Parkinson's. Unfortunately, you can also see drug-induced situations. Maybe you're at a party and you get exposed to a recreational drug. We don't know. Again, even these things, it can affect and trigger our genetics and open up and unlock these genes. We don't know viruses that we're exposed to. Um, and there's a misconception that, like you said, it has to be only old age. I mean, I think we're still going to learn as time goes on that what's to say that COVID has put us stress on our system when those who've been exposed to it, when they got the mental clouding and the long haul symptoms, maybe those patients have been the ones that are more likely to develop Parkinson's or other, neurological conditions. I'll tell you something really interesting that I think this is what I come across with me and my physician assistants we see is those who are exposed to a lot of anesthesia and extended periods of anesthesia. Your brain's not meant to be put down in such a way, and we don't know how anesthesia slows down those brain functions. But we see that there is a high correlation of people who've had numerous surgeries, back surgeries, heart, knee surgeries. I mean, multiple surgeries, not just like one time going under, but there may be some correlation of these that aggravate the brain and the nervous system that then puts us at an earlier risk of Parkinson's.
Whoa. I had to write this down because these words are very hard for me to pronounce. So if I do not pronounce them well, just please help me. There's a difference between cervical dystonia
Okay.
and blepharospasm. How would you?
Blepharospasms. Hmm.
Okay,
Yep.
blepharospam, right? Blepharospam.
Blepharospasms, yeah. So the blephs, these are blepharal muscles and the spasms. So we get spasms of our eyelid, we get spasms of the neck. So and don't worry, these nomenclature, they are difficult. I mean, it's kind of like pronouncing the new drugs and medicines that come on TV.
Okay,
They're all difficult to enunciate and spell
those
out.
are. So I would think blepharospasms is when like your eye starts
Twitching.
twitching.
Yeah. Yeah.
Okay. How
Exactly.
do this differ from Parkinson's?
Yeah, so again, going back into, I'm glad that we get to do this 101s of movement disorders as well today, because there's spasms of the muscles. So again, I want to, as we jump into what those disorders are, Parkinson's typically involves tremors. And again, 20% of people don't have tremors with Parkinson's, but those tremors can be in any part of the body. They could be of the head, they could be of the hands or legs, but typically hands and legs is what we initially see. And then, so there's tremor, and it's a certain type of frequency, which is how we differentiate from others. There's rigidity of the muscles. So involuntary muscle spasms that are rigid, that the brain sends signals. There's slowness of the coordination. So fine dexterity, we're slower, whether we're trying to button and our dexterity of one hand or coordination of maybe even our facial muscles could be slow. So and then there's what we call postural instability. But when it comes to spasms and that rigidity, you can have other involuntary movements. Even the neck can become very rigid and pull forward, and it looks like it's kind of flexed forward, and we kind of get this kind of humping down flexion. Um, so that can be mimicked by something called cervical dystonia, and other people refer to it as spasmodic torticollis. And so the neck can be rigid, and it can also jerk and have some tremulousness or twitching and shifting. So it's again very uncomfortable for people, even socially. But there are patients who have what we call entericollis, and the neck's forward, and it can mimic Parkinson's. As disease of Parkinson's progresses, sometimes you can get this like flat facial expression, and that can even be early on. But usually the eyelids, it's hard to even open our eyelids with Parkinson's because you know how to control your movements, but you can't relax the muscle sometimes to open up the eyelids. So there's mimickers of what we call blepharospasms, and that's its own isolated issue that we don't understand the cause for it, but actually both eyelids want to close and spasm on you. So it's almost like triggers like light or wind. Once the eyes wants to twitch, now it's hard to again open, but these are constant spasms, and these involuntary movements really make someone like functionally seem blind. We've had some people also that mimic the spasms of the face called hemifacial spasms. So only one side of the face is affected, and the facial nerve that comes out as it sends its nerve signals to different parts of the face. There's constant twitches, and it's really aggravating for people. It's hard to focus, hard to be in conversation. They get facial pulling of one side, and that one won't typically look like Parkinson's, but maybe in fact people mimicked that as a stroke. So, but the blepharospasms and the cervical dystonia can be mimickers potentially.
So now that we're debunking myths, there is one myth that's all over the place, and and now that I have you here, I'm gonna ask you a lot of. When you're falling asleep and you are on the verge of falling asleep, and suddenly you just shiver all over, what's always said is that your heart rate is going so low that there is an electrical impulse that your brain sends to wake you up. Is that so, or is that a movement disorder?
Well, anything can become is some form of movement disorder. Now, we say disorder, it means it's happening pretty consistently. So some people can have these myoclonic jerks on a regular basis more than usual when they have sleep disturbances. So there are a lot of sleep issues. And when you're awake and then you go to sleep, it's not like a switch turns off. Like you go through stages of being awake to get to stage one of sleep, which is getting drowsy. And then you get into stage two of sleep where you're actually getting what we call sleep spindles, and you're actually getting into the stages of wanting to have a dream. And then there's stage three of sleep, and then there's REM sleep. So what happens again is when you're in that awake to sleepy state, that's when the brain's sending signals to the rest of the body to slow down, right? So maybe there's a signal to the heart, maybe there's signals to the muscles. Everything needs to slow down and get into what we call a parasympathetic drive. And then all of a sudden, some other signal hasn't been in the right gear and it kind of jerks your body. So we do see these involuntary jerks when, the brain's trying to say, look, I may want to stay awake, but my muscles or my body is trying to sleep, or vice versa. And then you get this jerk-like movement. And again, I always look at it as like different gears, like they just haven't got into that right gear or stage that it needs to for the whole body to appropriately go to sleep. And then I see that a lot with things on the mind before we go to sleep, right? Maybe we've had some stimulant, some coffee, maybe even alcohol. Alcohol, as it breaks down into sugars, can be both a depressant and a stimulant, and it really disturbs our stages of sleep. Probably one of the worst things that we can do is drink before sleeping. And so keep sugar levels low. I think that's an important thing to avoid those myoclonic jerks. But there are some people who themselves have sleep problems that they should actually go and see a sleep specialist to see what's going on and why they have movement issues in sleep, because there are some people who move in their sleep and their legs actually look like they're pedaling like a cycle, and it's called periodic leg movements to sleep. And then there's a lot of actually patients with Parkinson's who get something called restless limb syndrome. And restless limb syndrome, RLS, is where you're laying down and then you get this uncomfortable urge to move your feet or have to move to get comfortable so that you can then finally fall asleep. So there's actually a lot of sleep disturbances associated with Parkinson's.
So I think one of the conclusions we've come to is that there are a lot of conditions that mimic Parkinson's, but are not actually Parkinson's. So I imagine that misdiagnosis is a big issue. What are some of the most commonly mistaken conditions?
Yes, I would say, and again, this list isn't going to be like necessarily all exhaustive of it, but number one is atypical Parkinson's, which is not our really slow disease of decades type of Parkinson's. It's the fast type. They call it multiple systems atrophy, progressive supranuclear palsy, dementia with Lewy bodies. These are mimickers. They look like Parkinson's, especially early on in the first 2 or 3 years, and it progresses very fast where one is not as responsive to our typical medications that we prescribe to control the motor symptoms of Parkinson's. They can affect the system extremely fast, and that's when we have potential issues of of falls and complications, very fast memory issues. So those are, we call them the atypicals. Um, or in the past, we used some Parkinson's plus. And then there's drug-induced Parkinson's. Again, there are mimickers. Some people on medicines for major depression. Some people on medicines for like severe nausea, and it can block dopamine pathways. So again, as we talked about, the 101 of Parkinson's is a state of low dopamine. And if you mimic it by blocking dopamine with medicines, then you'll see that someone can look slow, stiff, or tremulous, and then have that mimicker. I commented earlier, normal pressure hydrocephalus, which is water in the brain, this the so-called ventricular system being kind of enlarged, puts pressures on certain structures so those areas don't get to function well. Essential tremor, also known as familial tremor. It runs in families where people get a jaw tremor, voice tremor, head tremor, and even hand tremor. But those tremors, again, are mostly with action. So if people are trying to write, they have a lot more scribbly type of coordination. They're trying to drink from a glass and they're very shaky. That's an essential tremor. Whereas Parkinson's is more slower, and then their tremors are typically at rest. So patients with Parkinson's, when they're sitting, then the hand wants to then quiver, or you may see a lip tremor with Parkinson's. You may see a foot tremor when they're resting. So those are the subtleties of difference between the essential tremor. And that one actually, when you think about diagnosis, essential tremor outnumbers Parkinson's almost 10 to 1.
Wow.
Yeah.
Wow. So, Parkinson's, of course, affects movement, um, which definitely leads to affecting mood because when you're in no control of your body, it probably makes you anxious or stressed or depressed. Um, but as far as I know, it also affects memory, and I've heard that it can affect smell. Is it so?
Yeah, sense of smell. So
So, yeah,
people's
the sense
people's
of smell.
sense of smell is reduced. Yeah. So it's interesting because, in the pandemic, in the early stages, everyone's losing their sense of smell. And so, when you come into the clinic, the first thing I would ask actually when I'm talking about patients with Parkinson's is like, how's your sense of smell? Have you reduced it in any way? Have you lost it? And they're thinking my questions are related to COVID. When in fact, we've been asking these questions for decades. But what we do know is patients with Parkinson's lose their sense of smell even a decade or two before the diagnosis. There's actually higher rates of constipation a decade or two, and that works on the serotonin pathways. There's sleep disturbances that happen a decade before or 2 decades before, where patients may fight in their sleep, yell in their sleep, and feel like they're being attacked. And that's called a REM behavior disorder. Again, part of the serotonin syndrome. And then the constipation, as I commented, is serotonin. Mood is based on serotonin as well as dopamine. So people have a reduced mood, lack of motivation. They're not depressed in the context of major depression of suicide, but they're in the context of, I don't want to go out as much. They're not as sociable. Again, more flat affects, and their kind of aura seems diminished. And again, a lot of spouses will come in or family members will come in and say, you know, my loved one doesn't want to go out as much, isn't as interested in hobbies that they once were. So we see those type of reduced mood. Now, anxiety is unique because anxiety comes in different flavors within the world of Parkinson's. Sometimes it's a social anxiety. Um, and it's rarely that they get panicked, like again, to like a fear of heights or anything like that. They just don't feel right. Maybe even walking, they feel anxious about their coordination as far as that goes. I have one patient I remember early on in my career would say he gets anxious going to a doctor's office because he doesn't want to sign. He doesn't feel comfortable coordinating and wanting to use a pen to even sign in. So, anxiety can be some form of different phobias, but it's variable. It's definitely variable.
Why is it so wide ranging? Why is it, I mean, because one would think, okay, it's just the movement, but why? What's the
Yeah.
explanation for it to be so
Yeah.
so wide ranging?
In real estate, they would say location, location, location. And the same thing goes with neurology. The brain's all about different locations. Within the brain structure, we have our visual system for what we see. We have our hearing areas. We have our cognition and processing. And cognition, it's its own podcast that we can talk about later on. But within structures of brain, there's different types of neurotransmitters, and even we use dopamine throughout our nervous system in our brain, but in different parts, dopamine is very important, or serotonin is very important, and that's why we see that this is a degeneration of these neurotransmitters and pathways. That, again, it's not just one chemical in the brain that is not firing. The dopamine pathways go to are attached to serotonin pathways, which again send signals to the heart. And then our nerves that come from our brain and come to our heart, come to our areas of respiration, come to our sense of feeling, to our what we call peripheral nervous system for our sense of smell. I mean, these are all associated with Parkinson's because, again, where the connections go. So I wish it was a simple disorder like a cough and cold. We can just here take this and we got rid of the bacteria that was the problem, right? Unfortunately, something triggered this pathway and these signals, and it's not as simple as it's just one area. Unfortunately, it signals and affects multiple pathways that even get to our feet, to our bladder system. We have people who have urinary urgency with Parkinson's, but because of the numerous neurotransmitters, right, that are involved. And luckily, again, fortunately, working together with other labs, research labs around the US, and we're getting better coordination for that research. We're seeing that there may be some commonality of uh, to reestablish those connections better.
Okay, so according to what you've been telling us, my question is Parkinson's one disease, or are there many types of Parkinson's?
We look at it as a syndrome. I think that's maybe the best way of saying it's a syndrome. And when we say Parkinson's, and you've seen one patient with Parkinson's, you've only seen that one person with Parkinson's, because there are different versions within the slow type of it. So there are people who are tremor predominant, that they may shake, right? So we say tremor predominance, and there's definitely shaking that you see, but tremor does not have to be that first symptom. Sometimes it's slowness of coordination, and that a patient may have just pure slowness. We call it bradykinetic or akinetic Parkinson's. Then there's this akinetic rigid type, which the muscles are stiff and slow. And so patients look like they can't coordinate because the muscles are just so tight. They look like they're shuffling their feet. Then there's another form of typical Parkinson's where they just have postural stability. They stand up and their balance is off, or they're a little bit more hunched over. And that could mimic someone of more elderly status, but in fact, it's part of Parkinson's. And so those are the ones that we, you know, have patients come into a clinic having delayed diagnosis because they never saw a tremor in the first place and they just thought it was part of an aging process, right? And so those type of features of Parkinson's can be variable. There are people who maybe they just have a softer voice. I mean, they don't even have any tremor. They don't have much rigidity of the muscle, but they have softer voice. And that's another thing, that there's slowness of these muscles here. And that could be one of its first symptoms of patients, developing Parkinson's. So the unique thing about Parkinson's is, even though there's different types of presentation, it's not like a specific order of symptoms you have to have, which is why there's such a variability.
Sometimes I think it's because of the over connection that we now have, and because we're looking at media all the time, and if it's not media, it's X, and if it's not X, it's Instagram or TikTok, and there's information all over. But it seems as if though there was more Parkinson's now than before. Is there more Parkinson's now, or is just like the feeling we get because we are so over informed?
I think there's a right answer with being over-informed. I mean, I think people are their own advocates. They have their own podcasts. I mean, they have their own access to, Facebook. They may be reaching out on Instagram and saying, hey, I've been diagnosed. So there is this better network socially. I think, with insurances having more accessibility for patients to come in, I think that opens up and then has better access for diagnosis. And I think we weren't aware of how prominent Parkinson's was. I think our numbers and evaluation of people with Parkinson's has been always underestimated. But then at the same time, when we're dealing with baby boomer generation right now, you know, we expect numbers to be increased. We don't know what we've been exposed to over the last 20, 30 years, which again, I think has increased these situations. Our GMOs can probably be playing a factor. Again, exposure to certain foods, maybe the lack of variability of the food production. Um, I think that we're going to see some trends. We're going to see trends that there's more and more of, but there is a higher number of incidents of Parkinson's for sure. And in our area, in Orange County, California, we're seeing that this used to be beautiful orange groves. And again, with pesticides and chemicals, McDonnell Douglas, which is now Boeing, there was different plants. There's aerospace engineering companies and certain chemicals exposure there. So I think that what we've been dealing with even technology and byproducts probably puts people more at risk as well. And so that's why I think we've seen this uptick.
What is the most rewarding part of treating Parkinson's patients?
Yeah, rewarding. I mean, I'll tell you, I hope I can practice medicine for a long time because I think every day has its own reward. I get to practice medicine where patients come in with potentially such a fear of the disease state, and we can calm down those nerves and really re-educate and remind them about the potential of what we can do. And we've talked about a lot of bad things that can happen symptom-wise of Parkinson's, but what we haven't talked about is the beauty of our response to therapy. We have medicines that can manage patients. We have things that patients can get back to living their life. And I'll tell you, I mean, I have patients who, even in their 40s and 50s, after diagnosis, they're still exercising, they're still going to a gym, they're in their 60s and 70s, and they're in the best shape of their lives. I have 80, 90-year-olds who are going to the gym for their first time, and they're keeping active. They're taking cycling classes. They're involved with swimming. So I have people who are again reestablishing like their second life. So when you're diagnosed with Parkinson's, you can actually be in the best shape of your life. You can actually get better because now we're actually dedicating. And I'll tell you, I think one of the most rewarding aspects of Parkinson's is giving people that second wind, that motivation. And it doesn't have to be so fearful anymore, right? Like it's this, okay, we can do this. And there's a gentleman who has written books with Parkinson's, and his name's John Ball. And if you're out there, John, you're again another hero. Um, I met you when I was in my fellowship, and he was at a book signing, and again, such a motivator. And he was there speaking to other patients with Parkinson's. And this guy, once he was diagnosed, ran a marathon every year and did so for over 25 years until I think he had some back or knee surgery. And so again, really important is that people can live well with Parkinson's, and that's what's rewarding, that we are working with them to get them better, and debunking those myths that that you have to just be limited.
I love that you're saying this because I do wanna end this episode on the hopeful side. Um, so you've dealt with Parkinson's and on many stages. What would your advice, three pieces of advice for someone that's listening to this podcast and has just been diagnosed Parkinson's and is, of course, terrified?
Well, number one is you're not alone, and go and seek. Number one, seek a neurologist who specializes in movement disorders. If you can, there's universities, there's those like myself who trained at a university and then have established themselves in a private clinic. So that's number one. Number two is don't give up. Right, like it's kind of like cancer. Don't give up, never give up, because there's going to be something out there that we're going to be able to stop and reduce. Um, and the third part Sorry, the second part about the don't give up, don't stop is make sure you're exercising within it, right? Like don't stop, meaning make sure you're a better version of yourself. Work at getting the best version of yourself. And the third thing is be involved, understand research, look things up. Um, Regardless of what we say about Dr. Google and not, get informed. I mean, there's beautiful websites out there, there's information out there, and there's also support groups out there. But not each support group is for everyone. And so, there may be young onset support groups. There's support groups for caregivers. And I think that's really important is that, trust your family, get involved, do your research with those that understand the disease state. Don't close yourself off. That's again, a key part of this is that, don't let this disease consume you and you have to live your life. I think the last part here is you got to live your life, because if you limit yourself, the disease not only consumes you, it defines you, and you don't want that. You don't want Parkinson's to define you.
I once heard you're not your disease. A disease is part of you, but you're not your disease.
You're not your disease. It's true.
Dr. Thakkar, thank you so much. It's a pleasure as usual. I'm looking forward to our third episode of the Caring Neurologist, and I'm going to leave you with your audience to tell them whatever you want to. Until next time.
Well, again, it's been a great episode. As we're going through this and we're developing more content for education, again, as we talked about the 101s of Parkinson's, it's so important. Get out there, get evaluated. Don't let things build up and accrue. We have ways of helping people, and fortunately, we have therapies that are out there, and we have research that's going to cure this disease. So, again, we're excited. In the meantime, let's get the education rolling still.
Thank you so much.
Take care.